Thank you so much. So I'm going to be speaking today about school-based telehealth enhanced by interactive technology, and I'll also tell you a little bit about our program called Hawaii Keiki. So we can go to the next slide. So the agenda I'll go over today is just a background significance of school-based telehealth in general, an overview of the Hawaii Keiki program and the progression of our school-based telehealth program. I'm going to explain to you about our program called the Virtual Keiki Care Program, which uses that interactive technology. I'm going to be reviewing a program evaluation that we did for that program, and that included review of data from RN surveys describing barriers and facilitators for utilization. Then I'll review with you the utilization we had in our 2022-2023 school year, as well as some updates that we made to our program, and then recommendations for others on how to build a school-based telehealth program. Next slide. So for school-based telehealth in general, it's currently present in over 1,800 public schools, servicing over 1 million students. And it's found to be very important to extend care to rural areas, especially areas where the school nurse may be the only medical provider that is regularly seen by students. It also enables one provider to access multiple health rooms. And so using one single provider, you can expand the scope of care in several health rooms. It also saves families time and money as they're able to avoid transportation costs and missed work days to seek care off campus. Next slide. School-based telehealth can also help keep students on campus and reduce absenteeism, as was discussed in the earlier session today. It also allows for increased interprofessional collaboration and education, and the American Academy of Pediatrics has endorsed school-based telehealth programs, and especially for chronic conditions. And of course, COVID-19 has highlighted the benefits of school-based telehealth. Next slide. So a little overview about the Hawaii Keiki program. The Hawaii Keiki program is a partnership between the University of Hawaii at Manoa Nancy Atmosphera Walsh School of Nursing and the Hawaii Department of Education. Our mission is to keep keiki, which is the Hawaiian word for children, healthy and ready to learn by providing access to health services in Hawaii public schools. The Hawaii Department of Education is basically one very large school district that is divided into 15 complex areas geographically. Our program started in 2014 with 6 mastered prepared nurses, which were composed of APRNs, that's an interchangeable word for nurse practitioners or advanced practice nurses, as well as other master's prepared nurses. The program expanded by 2019 to include 14 APRNs and 4 RNs. Next slide. And then we actually benefited from some of the funding that came about with COVID. We received CARES Act funding that enabled us to expand in the 2020-2021 school year with the onboarding of what we called COVID support RNs at that time. And we were able to hire 1 additional RN per complex area. In the following school year, we again received some additional funding from Department of Health that allowed for further expansion. And in that expansion, we actually transitioned our COVID support RNs to become what we called complex RNs. So we hired 1 RN per complex. Just to give a little background about the way that our school district is divided, we have 15 complex areas. Each complex area is composed of 2 to 3 complexes. And a complex is composed of 1 high school and the feeder schools. And so our nurses, our RNs, are usually 1 per complex. So they may cover between 2 to 7 schools. And then our APRNs, we only have 1 per complex area. So they cover between 11 to 28 schools. And usually they have 1 location as their primary location at a school where they have their office, and they go out and visit and service all of the other schools in their complex or complex area. We were also able to hire what we called school health support staff. And those were either medical assistants, certified nurses, aides, or community health workers who we tried to onboard 1 per school during this past school year with the funding that we received. As of spring 2023, we had 18 APRNs, 38 RNs, and we had about 170 school health support staff. But due to the end of some component of our federal funding, we are downsizing that in the coming school year. We're going to be having about 100 of them, and we're just transitioning the name of their title to health technicians for this coming school year. Next slide. So our staff is spread across all of the islands in Hawaii, which include Oahu, Maui, Kauai, and Hawaii Island, which is also called the Big Island, as well as two small islands called Molokai and Lanai, which are technically part of Maui. And the services that we provide in our program include direct clinical services for students in the health rooms. We can do sports physicals and school physicals by our APRNs. We do health screening events, vision, dental. We also do case management of complex students. That could include putting together emergency action plans or what are called independent education plans. We also do a lot of health initiatives and education. So that can be things such as vaping prevention, puberty education, or training of emergency medication administration, such as EpiPens and Narcan. And we did a lot of COVID support, of course, in the last couple of years. That included education, helping families and students understand the guidelines of COVID testing we offered. We also provided contact tracing, and we supported COVID vaccine points of distribution. We also, in our positions, do a lot of supporting of what are called school health assistants. These are staff that are hired by the Department of Education, and they are non-licensed personnel who staff the student health rooms. And so they are at every school in Hawaii, and they're usually the first point of contact for students coming to the health room. And if they're at a school that has a Hawaii Keiki nurse, they can refer that student to the Hawaii Keiki nurse. Next slide. So Hawaii is uniquely positioned to benefit from school-based telehealth due to the geography of the islands. We're very spread out. Some areas are very remote. For those of you who may be familiar with Hawaii, there's some places like Hana, Molokai that are very far away from medical care. We also have a high need in terms of socioeconomic status. So we have about 256 schools and approximately 174,704 students. And of those schools, 170 of them are Title I schools, which is defined as having at least 40% of the student body coming from low-income families. So the very beginning of our telehealth program was in the spring of 2020 when the schools were closed. We wanted to find a way to continue to access care for our students, especially for those students who the school nurse was the only person they ever came in contact with as a medical provider. So we started out with a health hotline, which I'll tell you a little bit more about. And we also facilitated video-only telehealth visits at that time through what was called the DoxyMe platform. Next slide. So we set up this health hotline where families, as well as staff and students themselves, could call during school days from 8 a.m. to 3 p.m. We staffed it with both RNs and APRNs. We offered telephone triage for health needs. We also provided information just if people had questions about things like COVID guidelines, quarantine, isolation, local regulations. We also gave information about where testing could be obtained. And we also provided information about health-related resources, such as where was their federally qualified health clinic, where could they get mental health resources, as well as provision of free lunches that were being offered through the schools at the time. And then, of course, we offered those telehealth visits for DOE students. Next slide. So some of the types of health visits that we were offering through telehealth included management of acute issues such as a upper respiratory infection or a rash. We also offered providing refills for chronic medications such as like an albuterol inhaler, especially in the setting of closed pediatric offices. Many of our pediatric offices were completely closed during the beginning of COVID. And we also provided a preliminary visit with an APRN or nurse practitioner for mental health needs for students that might be awaiting an appointment with a mental health specialist, just to kind of do some case management to get started. And in the fall of 2020, we did have the return in-person learning for our special education students. We continued to offer our video telehealth visits, and we also started to do some from the students being on campus. Previously, they were always at home with the family and we would connect by video, but we started to do some video visits on campus in that fall of 2020. We started to also see some new types of requests for visits. Examples would be students who were being sent home frequently with a runny nose and they had allergies. They wanted some kind of medical note from a provider to avoid being sent home frequently. We also got requests for telehealth visits for clearance to return to school after having COVID-like symptoms. Next slide. So in the spring of 2021, we actually returned to in-person learning in Hawaii with staggered schedules usually. And at that time, we continued with our health hotline, which we still have today, as well as video visits. And around that same time is when we initiated our Virtual Keiki Care Program, which is what I'm going to focus on from here on. I did also want to mention we did initiate mental health telehealth services as well in the 2021-2022 school year using some mental health nurse practitioners, and they connect with students via video platform only for mental health services. So in late spring of 2021, our new program, which we called the Virtual Keiki Care Program, was piloted, and that's where we started using that interactive technology to conduct visits in school health rooms, and those visits were facilitated by our RNs. So this uses equipment that was called TidalCare is the name of the equipment that provides functions of a digital otoscope, a digital stethoscope, and a high definition camera. Next slide. So it's very similar to the technology introduced earlier today. It utilizes a handheld device, as you can see in the picture there, that has different attachments that enable it to function as either a stethoscope, an otoscope, or a high definition camera. The nurses were also provided with pulse oximeter and a blood pressure cuff. And this enables the RN to connect with an APRN who's working off-site and see a student in their health room. And parental consent is always obtained prior to any visit. And when the platform first started, parents were able to join by phone only, but they're actually allowed to join, or the technology has been enhanced such that they're able to join by video as well now. Next slide. So this is just another picture of the attachments. You see an otoscope there, stethoscope, as well as just a tongue depressor. There's a high definition camera for looking at the throat, looking at skin. And the RN and APRN will work together to develop a treatment plan and have the parent updated either live if they're joining by video, or we usually call them towards the end of the visit to give them an update. Next slide. So this is a sort of stationary console that we used in the pilot program, where you have just a drawer with the little attachments and an iPad. On the RN side, they use an app-based system. On the APRN side, it's web-based system, so it can be used from any computer or laptop. I'm going to show you on the next slide what the split screen looks like from the provider side. And from the RN side, they also see a split screen where on one side they're seeing the provider, and on the other side they're seeing the projection of whatever images are being carried over to the APRN through the device. Next slide. So this is what you see from the provider side. On the right-hand side, you can control the device. You can select different options, such as if you choose lungs, then your stethoscope function is going to start working. Or if you choose throat, your camera function is going to start working. And you also can indicate where you would like the stethoscope to be held by clicking on those different numbers. And the device is controlled by the provider. This picture is showing a patient using it on themselves. In the little window is the provider. But we usually have an RN who's the one actually holding the stethoscope on the patient or holding the otoscope in the ear. Next slide. And one thing that's really nice is the ability to record images as well as sounds. So for example, if doing an ear exam, you could take a picture of this, and then if you did a follow-up exam in a couple of weeks to see how that ear had healed up, you can do a comparison, which is really nice. And you can also do the same with lung sounds. Next slide. This is just a picture, and we have a little example video here of you seeing it in action.
So it's going to show us first, right, and then left, okay?
You want to do maybe the heart first?
Yeah.
Yeah. Oh, I see. Yeah, I hear it really
Strong?
well.
It's a strong beat.
Can you do a deep breath? Good. And so as you can see, we can do some talking of instructions about where to hold things and how to adjust the holding of the otoscope during the visit live. So next slide. Just a few examples. This is just limited really because we can see all sorts of things through this technology, but just some examples: earaches, skin issues, sore throat. We've seen a lot of strep. We do point of care testing, respiratory issues. We do COVID testing, stomach aches, and all of our nurses are also set up with medications that they can give in the clinic. So next slide. So an example scenario of an earache. In a previous process, if a child came to one of our health rooms that was staffed by an RN, that RN would then need to contact the family, recommend a visit to the PCP in order to see if the diagnosis of an ear infection needed to be made and if a prescription needed to be made. But using our virtual Keiki care process, the nurses can connect with the APRN or nurse practitioner offsite, who can then diagnose an ear infection right then and there and can call in a prescription or send it electronically from the hub facility. And this also will enable the student to be able to go back to class if they're not in too much pain. If they could be given just an ibuprofen, they could go back to class and family can pick up the prescription later after school. Next slide. So some goals of our Virtual Keiki Care Program is to expand that scope of services in the RN staffed health rooms to the APRN level. As I mentioned, we only have one APRN per complex area. So we are much more heavily staffed with RNs than we are with APRNs. When we first started this program, we utilized just one APRN statewide to service all of the locations where we placed the program. I'll tell you a little bit more about how we will expand on those number of providers later. We also had a goal to increase the number of families who benefit from the convenience of an on-campus visit with a Hawaii Keiki nurse practitioner, and to increase access to care for students with either financial or transportation barriers. Some of our students live very far away from medical services and they take the bus, an hour to school. So it's a big burden for families to try to go pick them up if they need to go home. So if we're able to keep them on campus, that's great. Definitely one of our biggest goals is decreasing student absenteeism. And then we also wanted to provide additional support to the school RNs working in that environment. In school nursing, you don't have the benefit of your colleagues on site with you or a provider on site with you if you're an RN. So this is just another way to support our nurses that are out in the field. Next slide. So when we started that pilot program in spring of 2021, we just chose 4 RNs. We chose individuals who had already demonstrated efficiency and receptivity to new programs in our Hawaii Keiki program. We also chose some variety in the different islands and wanted to include the neighbor islands that usually have less access to care. So we had 1 on Oahu, 1 on Kauai, and 2 on the Big Island, which is also called Hawaii Island. And we used 1 APRN who was the virtual health lead as well. The initial training we had was conducted by the Taito Care facilitators. They taught both the RNs and the APRN how to use the equipment and how to connect. They also taught our program manager how some of the administrative pieces like signing up for accounts. We did some presentations with the Department of Education leadership at the central level, and we also did letters of introduction for principals at the school level. We also created letters of introduction for families and students at the 4 pilot sites and for the school health assistants that I mentioned earlier, because we do depend on their referrals first to the RN to then have an RN have a patient that they can refer for a virtual visit. The RNs were also encouraged to do a demonstration of the equipment to their principals and to their SHAs. Next slide. At this time, we also required a training for our RNs in the electronic medical record system called EPIC. Previously, RN charting was done only in what was called Health Office Anywhere, which is a simpler school-based system. But because we're now doing provider level services, we needed them to learn EPIC, which was also used by our APRNs. We also provided them with those point of care tests I mentioned. So that could be strep tests, COVID tests, urinalysis sticks, pregnancy tests if age appropriate. We used that stationary equipment in the original pilot, and we went live in April of 2021 That gave us about 6 weeks of utilization before the end of the school year. In total, we only had about 3 to 4 actual visits conducted in that original pilot. And so we started our planning for further expansion in the fall of 2021. Next slide. So when we set up our planning for the next school year, we decided to expand to all of our RNs at the time, except for 3 very newly onboarded RNs. So it made a total of 14 participants that included the 4 pilot RNs. And we also conducted at that time a needs assessment with those RNs who had been part of the pilot doing interviews. We asked them questions about their students. For example, would your students benefit from having provider level services available to them in your health room? Or how often do you see a student who could be kept in school if provider level services were available to them on campus? And then we asked them some questions about themselves, such as how might you benefit from having access to a provider through interactive technology? Or how comfortable do you feel being the only licensed professional on your campus? So some of the results from those interviews, we had some resulting positive themes, such as the benefits to students by keeping them on campus, providing access to a higher level of care, easier and faster access to care for students, the possibility that the program could help alleviate barriers from COVID guidelines, and it increased the RN's own sense of support and scope. And some other resulting themes were barriers. Common barriers noted were communication with families could be difficulty in getting those consent forms back, time constraints, connectivity issues, occasionally lack of administrative support from the local principal, or feeling the need for training refreshers. So in the 2021-2022 school year, we decided we wanted to use mobile equipment this time. Instead of that heavy console, we set our RNs up with the backpack version, which basically is the iPad and a little stand, and then that handheld device, which they could take from one school to another. We trained them at the beginning of the school year. So our training consisted of one big Zoom training with all of the RNs, where we talked about the goals of the program, its purpose, details, how to use the equipment, and it included a live demonstration where we did sort of a mock patient visit. And then we set up one-on-one practice connectivity sessions between the RN and the APRN virtual health lead. And we also did one-on-one practice case scenarios where the practice patient, an actual practice patient was used for the RN to practice putting the otoscope and stethoscope on the patient and connecting with the virtual health lead. And we did another EPIC training for these RNs that were included in this program. We also created a visual workflow for the RNs about how to do the visit step by step. And those trainings were conducted in August and September of 2021. So we again did an introduction for our principals, our SHAs, those school health assistants, and families using an introduction letter. We also again encouraged the RNs to demonstrate the equipment to their principals and their SHAs. Overall, we had pretty low utilization in that first year. All of the visits from the provider side were conducted by the virtual health lead statewide. And just some contextual things going on in our Hawaii Keiki program at that time overall. We had some leadership changes in August of 2021. We also had very high demands on our staff for COVID support, both with the Delta wave in fall of 2021 and the Omicron wave in the winter of 21 to 22. We were also undergoing a huge staff expansion at that time, as I had mentioned to you previously, and our existing RNs were responsible for helping with recruitment, with interviews, helping with training all of those new staff. And then same thing once we started onboarding those school health support staff in February of 2022, those medical assistants and CNAs that we hired. So a lot of demands on our staff, and good timing on this one as well. We had a transition from our electronic medical record system in the school-based system from Health Office Anywhere to Infinite Campus. So that just added another burden of learning for all of our staff. So next slide. We also had one RN who transitioned to an administrative role. And so that left a total of 13 RNs in the program in that 21-22 school year. And in October, we decided to actually give that extra set of equipment to one of our medical assistants. Something that was interesting we noticed is that she had much higher utilization than any of our RNs. The types of visits that she was requesting sometimes would be lower level needs. For an example, a student coming in with menstrual cramps who might need ibuprofen. Our RNs can facilitate that visit just using standing orders without necessarily connecting via video with an APRN. So we had higher utilization with the MA, but maybe not to the same level of intensity of what the visit was for. We conducted a check-in meeting in November of 2021, where I asked the MA to sort of talk about how easy and wonderful the program was and her experience with the program to try to encourage increased utilization. And we also talked about the types of complaints that we would recommend for our RNs to refer for visits. And we reviewed each of those chief complaints in detail. So on the next slide here, we kind of made a pretty comprehensive list here, talking through with the RNs every single chief complaint here and why that might be good to refer to an APRN. Because we did have a lot of RNs who, kind of want to manage it themselves, don't want to make the referral, maybe don't think it's necessary. So we talked through all of these different types of visits and why it would be beneficial to refer for a virtual visit. Next slide. So we also started conducting our program evaluation around this time, where we were tracking our utilization. We were looking at it both by RN, by island, by school level, and by location for a 5-month period. And we surveyed our RNs halfway through the school year, so in January of 2022, to ask them about barriers to utilization as well as facilitators to utilization. There were also some questions in there about demographics of the RN, such as how long had they been an RN, how long had they been with the program, and how long had they been trained in the new Virtual Keiki Care Program. And in that survey, we also included something called the Technology Acceptance Model, or TAM, which is a verified tool from the literature that has been shown to measure perceived usefulness as well as perceived ease of use with new technology. And higher scores are generally associated with higher likelihood to adopt a new technology. So this was our overall utilization. Not a lot of visits, as you can see. We had just 1 in October, 7 in November and December, 2 in January, and 4 in February. This is just for RN visits. At the bottom there, you can see from the MA, we had a total of 25 visits from October through December. And this is with a total of 13 RN participants. So our smallest visits in October and January did coincide with COVID spikes. Of the 13 participants, all of these visits were actually conducted by only 5 of the RNs. So that means 8 didn't use it at all. The largest number of visits were conducted on the Big Island or Hawaii Island, and our largest number of visits were at the elementary school level. High school was second highest. And so this is just to tell you a little bit about our survey that we conducted as part of the program evaluation. So the RNs were given a 17-question survey that had both qualitative and quantitative questions. As I mentioned, asking about demographics. We also asked them about self-reported utilization. It was an anonymous survey. Asked them about perceived benefits to students, to themselves, barriers and facilitators, and then those TAM questions, which showed us perceived usefulness or perceived ease of use. So here are some of the results. We had 12 participants out of the 13, so only 1 nurse failed to complete the voluntary survey. 7 participants reported having been able to complete a visit, whereas in reality only 5 really had, but we think maybe some had remembered the practice session. So of those 7 who had recalled completing a visit, the majority of them said they conducted between 1 to 4 visits. Next slide. And then for when asking why perhaps they would not have been able to conduct a visit, the most commonly noted reasons were time constraint, 40%. Other reason was that the participant maybe felt that they did not have a patient who would benefit from a virtual Keiki care visit. That was about 40%. And then about 20% indicated internet connectivity issues. Otherwise, they also may have indicated a consent issue or communicating with families, similar to some of the results from the needs assessment. Next slide. In some of the demographic questions, we had about we had about 50% who had reported being in the Virtual Keiki Care Program for 5 months, a quarter who had been in it for 4 months, and a quarter for 10 months. Those were going to be those from the pilot. And then most participants reported having been a school nurse for about 1 to 2 years, 6 out of the 12. And the second largest group reported having been a school nurse for about 3 to 5 years. Next slide. When asked how well trained they felt in the program, the majority said they felt well trained in the program overall with a mean score of 3.83 on a Likert scale of 1 to 5. So pretty well comfortably trained. Next slide. When asked if they thought the program was beneficial to them, to their students and to themselves, the vast majority, 10 out of the 12, reported that the program was beneficial to their students in their interpretation. And 9 of the 12 reported they thought that the program was beneficial to themselves as the nurse. We asked if they thought that the program could be beneficial in facilitating interprofessional collaboration. 75% reported yes, they thought it could. We also asked, did it help them feel more supported in caring for their patients? And 83% reported that yes, it did help them feel more supported. Most participants also reported having a good understanding of which types of patients should be referred. And the majority also stated that they did not generally have problems in adopting new technology. These were the results of the TAM tool. So generally speaking, the TAM scores can also be interpreted sort of as a grade for how useful and how easy to use the participants perceive the technology to be. So about 6 of the questions are about ease of use, and the other 6 are about perceived usefulness. So as I mentioned earlier, higher scores are shown to be associated with higher acceptance of new technology. So on the perceived usefulness scores, we had a mean score of 26 out of 35. So that represented perceiving the technology as about 75% useful. And then on the ease of use score, our mean score was 33.5, and that represented perceiving the technology as about 79.8% easy to use. We also broke down the scores by looking at some subcategories of were they a user or a non-user, self-reported, how long had they been trained in the program, and then how long had they been a school nurse. Next slide. So we had high scores for both perceived usefulness and perceived ease of use. However, our overall utilization was still not very high. We did have slightly higher scores for perceived ease of use than for perceived usefulness. So overall, our nurses thought this is pretty easy to use, more so than I think this is really useful. But in the literature, it has shown that in terms of RNs specifically, it's more important that they perceive the technology as useful for them to actually use it. And we did see, of course, that our users, those who actually used the program, had higher ranges and means for both perceived usefulness and perceived ease of use than our non-users did. Next slide. So we also found that perceived ease of use increased with increasing time as a school nurse, but perceived usefulness decreased. So if they had been a school nurse for longer, they seemed to think the technology was less useful. They thought it was easier to use, but they didn't necessarily think it was as useful to them because they're a more experienced school nurse. This was consistent with the literature, which actually said newer nurses may be more ready to accept the use of new IT type technology in general. We also found that perceived usefulness was higher in those who were more recently trained. And so this also is consistent with the literature that early acceptance may lead to long-term use. And then the participants from the pilot, those who self-reported having been in the program for 10 months, they had the highest scores, they had the highest scores in perceived ease of use than in any other subcategory. So they thought the equipment was 91.3% easy to use. So that is consistent with the literature, which states that increased use of telehealth technology leads to increased comfort. So we also conducted some qualitative questions and some interviews, and we had a few overarching themes that resulted from that. which included barriers to utilization, which included training needs, some facilitators for utilization, which included training components, benefits to self as the RN, and then potential uses and facilitators, including interprofessional collaboration. So, oh, sorry. Yes. Did we have one slide right before that or no? Oh, no. Okay. Thank you. So barriers to utilization that came as a result from those surveys and interviews. Again, time constraints. That's also consistent with the literature. It seems to be one of the biggest barriers for nurses to use telehealth. Epic, several of them mentioned having to use 2 electronic medical record systems was overwhelming. And also there was a big learning curve in how to use Epic. Sometimes they cited the problem was lack of SHA referrals. If the SHA doesn't refer this patient to the RN, then the RN doesn't have a patient to then refer to the APRN for a telehealth visit. Sometimes internet connectivity could be a problem, difficulty obtaining consents. Some said, well, there's a PCP or an urgent care really nearby and the parent just wants to take them there, so they don't want to use the telehealth. When we had to do that transition to our new EMR for the school-based system, that was also cited as a barrier, that they were kind of overwhelmed with having to learn that. And then, of course, the COVID demands. Many of them felt like they were just so busy with contact tracing or supporting some kind of outbreak in their school that this, was not their priority to do these types of telehealth visits. So a couple quotes from the nurses. TytoCare and the machine itself is great. It is the logging into Epic and making sure I'm in the correct screens and scheduling and charting, only because we do not use Epic daily. Another one said, I have not used all the features and have not rolled out entirely due to the transference of our medical systems. It has been hard to check for consents. Also due to COVID, the policy is to send students home. So we heard that sometimes where the RNs would say, well, the kid's going home anyway, so why bother doing telehealth? So we really, had to work on that to communicate that it still would help the family if they didn't then have to make an additional trip to the doctor later. Next slide. So facilitators for utilization that the nurses cited included thorough training with practice scenarios, guidance of the program facilitator, and frequent refreshers. They found the TytoCare training help desk helpful, and good internet connectivity was a facilitator. So a couple quotes were, training opportunities were good, regular check-ins and trainings helped with rollout and comfort level. Another nurse said, things that help facilitate were the training done over Zoom, hands-on training, the step-by-step guidelines that were printed so that I can refer back to them, and good internet connection is a must. Nurses also cited the benefits to their students included increased access to care. They found that it mitigated barriers to seeking care, such as time constraints, transportation, or missing work, that it could reduce absenteeism, prevent a delay in care, and could assist in situations where the parent might not follow through. So a couple quotes were, it provides a student with the means to receive healthcare who would otherwise not be seen or evaluated by a medical professional. Some of our school communities decline to go for a variety of reasons, such as language barriers, fear of financial burden, and because of having no transportation. Another nurse said, there are many students without insurance or money. Students are ill and in need of medical care, and many are also in need of medication and a prescription. Students often go weeks without care and sometimes never receive medical care. Virtual Keiki Care is free, convenient, and easy to access. So for benefits to themselves as RN, they stated it helped them expand their scope of care, it helped them learn new skills, and it increased their confidence. A couple quotes included, it helps me provide a higher level of care and helps me have someone to help me when my students have something going on that I am not comfortable treating. As an RN who has primarily done administrative work, clinically, I love to be able to consult with a nurse practitioner. It makes me feel more confident in my assessment skills, and I learn new assessment skills while listening to interviewing. So another theme that came from our qualitative results were potential future uses and future facilitators that were suggested, as well as including interprofessional collaboration. So RN said that the training could be enhanced with more practice scenarios and with instructions with easier to follow steps. Suggestion to involve pediatric specialists, to use our school health support staff in assisting with conducting those visits, to increase advertising, to involve the SHA more, to consider use of school physicals if possible, to bring the program to more schools, and to use the Virtual Keiki Care Program for COVID-19 care. So one RN said, try to get the SHAs more on board. If they see something, that they immediately go to Virtual Keiki Care, even if it's something that the RN can't manage. Another one said, I think for fairness and equity for all, I feel like we should have a way to benefit every student, not just my students. I think there needs to be a way to take it to the other schools. I'm not sure how that would work. It would be good to take it to the Title I schools. The schools that are further out would be perfect. There is a lack of specialists there. So some takeaways from that program evaluation: the minority, just 5 of the participants, were able to successfully utilize the program. We had a total of 21 visits conducted in the 5-month period, plus 25 by the medical assistant. The majority of the participants found the program useful and beneficial to the students and to themselves. There were reported high rates of perceived usefulness and perceived ease of use. And participants reported an increased sense of support, comfort, and confidence, and felt that the program enabled interprofessional collaboration. So overall, the Virtual Keiki Care Program was successfully implemented as it was intended to be used, but with further work needed to increase utilization. So we started our planning for the 2022-2023 school year. And we first, of course, expanded the number of units that we had. We went from 13 to 22 locations. We had 21 sets of equipment, and one of them was being split between 2 schools. We plan to shift units from non-users to different nurses. So from non-users or very low users to newer nurses, because we found that the newer nurses seemed more adaptable or receptive to this, we decided to give the equipment to a lot of our new hires who we hired in the 21-22 school year. We also decided to emphasize neighbor islands and remote areas again. And we decided we needed to meet more regularly. So we set up monthly meetings with all of our RNs and our school health support staff in the program, where we would look at case studies, talk about, types of visits that had come through and referrals in the previous month. We also looked at utilization by site. So everyone could see kind of a graph of, oh, I had 5 and I had 3 and, I had 8. So could it help encourage utilization? And we also could get ongoing feedback. We also anticipated in this coming school year less confounding factors. We were not having a big new expansion of staff and needing to orient people. We hoped that we wouldn't have big COVID spikes, and we were not going to be dealing with a changing EMR system. We also decided at that time that we would go ahead and remove Epic from the workflow for the RNs. And so we just left it to the providers to take care of all of the Epic pieces. And therefore they only had to chart in that one school-based system called Infinite Campus. And then we created some written checklists and guidebooks just for more written materials to support the RNs. And we also created some later for providers. So we did another training in the summer of 2022 and the fall, and it was similar type of training where we did a big Zoom meeting. We did some live, demonstration. We set up one-on-one connectivity practice sessions and mock scenarios. We also had an educational presentation talking about the different types of chief complaints that are good to refer and why. We requested that the SHAs participate in these practice sessions. So sometimes we would ask for the SHA to be the practice patient. We really wanted the SHA to see live how that program would work so that hopefully they would refer more students to us as well. We did also train all of the SHSSs that were located at sites that had the VKC program, Virtual Keiki Care Program. And at our trainings, we kind of set an expectation with our staff that they should be able to conduct a minimum of 1 visit per week at all the sites. So wasn't considered mandatory, but essentially saying to them, we really think you guys can find at least 1 patient per week that you could refer for a visit. So please try to do that. And, if you're not meeting that minimum, we're going to need to do more practice visits and things like that. So not that we're trying to dig up patients, but just that, we know that we don't want to be missing patients. And so we really felt that there were a lot of missed opportunities probably. So we also did train some more providers that year, and we created kind of a calendar of who the APRN was for statewide coverage for the day. We did a training for those providers, and that training was done first with the Zoom training, and then having them join in live via Zoom to watch a conducted real visit with a patient that was being done by the virtual health lead. And then we also recommended that they do a practice connect with an RN. We also asked our Title Care facilitators to help train our IT staff so that maybe they could offer a little bit more troubleshooting for when we had technology issues. So this was our utilization in the 2022-2023 school year, which was a huge improvement. So this is a breakdown by month. And we had a total of 516 visits in the 2022-2023 school year. January was one of our biggest months, April as well, but overall extremely increased numbers in our utilization. This was a breakdown by school level. Again, we found elementary to be where the most number of our visits were conducted. The data is slightly skewed because we have more units at elementary schools than we do at our high schools, middle schools, or K through 12 school. But overall, we think the greatest need has been in elementary school and second in high school. We do have a couple of K through 12 schools as well. This was just a percentage breakdown. So 53% of our visits were done in elementary schools, 21% in the high school level, 20% in middle school, and 6% in K through 12. So we did make some adjustments over this past school year, 2022 to 2023. Because we were having such increased utilization, our one provider for the day was sometimes feeling overwhelmed and not able to conduct all of the visits that were being requested. So in January, we decided to train all of our complex area APRNs on how to be providers for virtual Keiki care visits. And we started having them serve as the backup. So if that state provider was busy, statewide provider was busy, she would say, please go to your local complex area APRN to facilitate this visit. We also started setting up provider-only meetings where just the APRNs would meet and talk about changes that might be needed, or there's a lot of little details and workflow things like labs and stuff like that that have to be figured out. We did notice over the course of the year, we occasionally got requests for telehealth visits from RNs that were not part of the Virtual Keiki Care Program. So if we did get a request for that, we would still conduct the visit doing video only. So we did want to support them in that way. And then something that helped us a lot in February 2022, we trained our data clerk on how to do the registration and appointment creation for all of the visits. So for those of you in school-based care, you may know that nurse practitioners or nurses in school-based telehealth have to do all of their own registration. A lot of times they have to register the patient in that medical record system, create the appointment, check the insurance, all of that, because we don't have front desk staff. So we tried to create a similar thing like front desk staff by having our data clerk support that statewide for all of the visits. And it actually helped us so much offloading our providers, and to the point that we thought we can reintroduce the Epic piece to the RNs. We had removed that from the workflow because it was such a huge barrier for them because they had been being asked to do that appointment creation and registration. So now we were asking them, could you please just put in the vital signs, the chief complaint, maybe a little brief RN note in there telling like some of the history. The provider would still, of course, do the progress note, the main progress note, and billing and everything. But that reintroduction of Epic in April of 2023 did not result in any decreased utilization. And we also told them they could sort of scale back the charting that they were doing in the school-based system of Infinite Campus, that they could write something very brief there and just say to see Epic note. So that helped facilitate reintroducing Epic without decreased utilization. So our plans for the coming 2023-2024 school year, we are going to have our complex area APRNs become the first call now for all of those virtual visits instead of using that state provider. We're hoping that will help with utilization as well, because that APRN already has some connection in the local community, is familiar with some of the resources in that community, and that provider can go physically to the school of that RN and sit with her for the day and say, hey, next time you see one like this, send it to me through Virtual Keiki Care Visit. So we're hoping that that will help continue to increase our utilization. We're still going to have a backup state provider in case that one APRN gets too bogged down. If she has 2 or 3 nurses in the program and getting too many requests at once, we still will have that backup. We're again going to move the equipment from places that had low utilization in the past school year to new locations. And again, most likely we're going to give them to newer nurses who are more recently recruited. We're also hoping to put a little bit more emphasis on the mobility of the technology. So as I mentioned, we had set them up with this backpack setup, but we haven't really emphasized asking them to carry it to different schools. There are some barriers with that. Largely, the biggest one is connectivity. Every time they move that equipment, they have to reset up their network, and that can take some time. So we haven't used it in a mobile way very much, except for that one nurse who uses it between 2 schools, but we want to use it in the coming year in a more mobile way. We're also going to be starting a charter school program where we're offering these virtual visits with the use of a health technician. And in the coming school year, we're probably going to do provider surveys and interviews to get that same sort of feedback that we got from the RNs, from the APRNs this time. And we'll hope to increase advertising and education about the program to our stakeholders. So some guidance from the literature in general, if you're going to implement a school-based telehealth program, they talk about important steps, including the planning phase, the needs assessment, training is very important, advertising, implementation, and then of course that evaluation piece. You want to obtain input from all of your stakeholders. You definitely want to have very thorough training and good technological support, and to have some individual adaptability of your programs. Next slide. And then so some of our recommendations for setting up a school-based telehealth program is you want to ensure your trainings are very thorough and complete. You should include some written materials for additional support. We highly recommend having regular check-ins, such as monthly, where all participating team members are there, case studies are looked at, utilization is looked at, and participating team members can make suggestions and adjustments to the program can be made. You want to assess the receptivity of your staff to the program with surveys and with regular opportunities for them to provide feedback. If they're telling you, here's why I'm not doing it, this is really inconvenient, or what can you do to make it easier for them to use? And then we recommend introducing new components gradually. So we sort of learned the hard way about introducing everything all at once with that epic charting. It seemed like more successful if we introduce different components slowly. Also, I think it may be beneficial if you can train end users first with a few providers the way we did, or even with just one preliminary provider, and then later expand to new providers so that you're not having new people on both sides. So brand new end users and brand new providers, both of which you're trying to convince how this program is good and useful and that they should use it. And then we recommend doing mock scenarios and practice connectivity sessions. We also encourage the end users to refer all types of visits. So I had to say that several times over the course of these 2 years, don't feel like you're not doing a good job if you are referring a patient. That some of the RNs want to feel very autonomous and independent, that they don't need to make a referral. And so we had to encourage them that this doesn't mean you're not able to handle it. There's a lot of benefits for why you should refer. On the provider side, you need to discourage them ever declining a visit. Unless it's something that just needs to go immediately to the emergency room, they should try not to decline any visits that are requested by RNs. You want to involve the stakeholders in the introduction of the program so you get buy-in. You need to advertise well to all of your stakeholders, students, parents, teachers, and other sources of referrals. Start new RNs in the program close to the time of hire. Use some champions, so your high users can share at meetings, can be a resource to your other users who are not utilizing it as much. Make sure you have good technological support, good Wi-Fi connectivity, and then have a designated individual if possible to do your registration and appointment creation for all your visits. So this is my contact information, and this is our website for the Hawaii Keiki program. And I know there were a lot of questions, so I'm going to try to
Yeah.
jump on those right now.
All right. Thank you so much, Kabari. There was a lot of
Yeah,
really good information and content shared. We did
thank
have quite a
you.
few questions submitted. I do want to say we are a little short on time, so we're going to try to
Okay.
go through these quickly. I am going to encourage people and kind of volunteer Kabari. She's been decently active in Huva. I saw her at the networking session. So if you post your questions in the Huva Q&A, she will be able to revisit those and probably get you a response. So please post them in the Huva platform as well. Question one, I'm going to talk about cost too much. So for the RNs, did the RNs have access to asthma equipment, i.e. albuterol with spacers or nebulizers?
Yes, they did.
Did the RNs give vaccines as well?
We are not set up with vaccines at this time, but we are looking to become vaccine providers.
Sweet, sounds great. How many days did it take to train the RNs and SHAs to competency? Anything that you learned during that experience that would have made it better, improved?
Yeah, I would say it probably, that preliminary Zoom training was done over about 2 hours, and then we would set up the one-on-one sessions, which each were about half an hour. But I would say it probably took them about a month to start to feel like they understood it and knew how to use it. As far as improving the training, I think if you have the ability to go there in person, it would be great. So it's difficult in Hawaii. I'm in Maui, and I had RNs I'm trying to teach on Oahu. I can't just hop over to their school and be like, here's how you hold it, here's how you use it. So if you have some ability to go physically there and help them with it, I think that would help a lot too.
Definitely. With that, does each island have an FQHC part of this program?
So we do partner with our local FQHCs, and yes, each island has at least one FQHC, but they're not involved in this program. We're kind of lucky because Hawaii Keiki has providers and RNs. I know in a lot of school-based telehealth programs, the RN works for the school district and the provider works for an FQHC or like an academic center. So for us, since we're all part of the same program, you hope that that leads to increased buy-in, really. But as you can see, still that takes time.
And can we ask, why did you choose to not staff LVNs as well as RNs?
We have not opened up very many of our locations to LVNs. The only place we have opened up for an LVN is for Molokai Island, just because we've had such difficulty staffing there. So generally our program, we hire BSNs in general. Yeah.
I'll ask one more quick question, if it's cool. How do your nurses check to see if a student has completed consent? Currently, this person is working for a school-based program in Texas that uses Epic and TytoCare as well.
Oh, nice. So we have a Hawaii Keiki consent form that includes verbiage in there about telehealth specifically. We send those out at the beginning of the school year, and if a student has one completed, it's uploaded in our school-based electronic medical record system keeping. But if it's not in there, then we can send them it electronically at the time when the visit is being requested. So if a student comes through for a referral, we look them up. If there's no consent in there, we'll call the family and say, would you like to have a telehealth visit? And we're going to need this consent. We'll send it to them electronically. We do obtain verbal consent for the telehealth visit, even if we already have the consent form for the Hawaii Keiki program from the beginning of the year.
Okay. Great to know. More consent's always great. I think I'm going to pause there. I've copied, I see a couple more questions that are in the Zoom. I've gone ahead and copied them into the Huva platform. So Kabari, if you wouldn't mind, I know you'll probably be here tomorrow too, hanging out. So if you wouldn't mind taking a look at those questions and giving some responses to those as well. This has been a really informative session for me. I really want to say that I really enjoyed the quotes and real feedback from people doing the work. That was really valuable. So thank you so much for sharing all of this today and bringing this presentation. We really appreciate it. And
thank you.
See you tomorrow. So thank you. All right. And that's to everyone. We hope to see everybody tomorrow. So if you'll join us again. answer the polls, take your survey. Thank you.
Thank you.